Good day all. My name is Dr. Bahati Moseti. I'm an emergency physician practicing in Perth, Western Australia. And I want to thank you all for creating time and enabling some time to join this ECG workshop. Most of all, I want to thank Dr. Washira and team for making this conference possible despite the disruption caused by COVID-19. You guys have worked really hard to bring this meeting and this conference online as a virtual meeting. Okay, as I said, I'm going to talk about some ECGs, and I'm just going to start now by connecting sharing my screen. So give me a minute. Okay. All right, there we go. All right, so welcome. I'll be talking about killer ECGs today. And I know in this room, there's a lot of experience. We look at ECGs every day. Every minute you're on the floor, someone will shove an ECG on your face. Oh, doc, what do you think about this? I know there could be cardiologists in this room. There could be electrophysiologists, but everyone has their own approach of how to interpret ECG, rate, rhythm, axis, etc. But that is not what we're going to talk about today. Today, we're going to talk about killer ECGs. In the next 1 hour or so, we're going to look at the real bad ECGs, real bad stuff. Some we may have seen before, some might be once in a life opportunity to see. But if we miss this, there's a potential bad sequelae, devastating sequelae, badness to the patient. I'm going to divide my talk into 3. And it's going to be really case discussions. I present an ECG and you have a look at it, and just some highlights on ECG, some interesting highlights, and we discuss about management. So I really would be happy if you participate. You could, I think, ask questions or answer questions by typing, sharing with the moderator. All right, so a few cases, I said clinical cases. It could be cool if we talk about these creatures today, but I want us to concentrate on the deadly ECGs. So are we ready for the deadly ECGs? Yes, I think we are. Let's kick off with our first case. Right, so the first case is a 45-year-old male who presented to the ECG complaining of indigestion for 1 hour. He was nauseous and lightheaded. His blood pressure was 110/70 and his heart rate was 70. So look at the ECG, and anyone in the audience who can tell us what's happening? Okay, yes, there is an inferior myocardial infarction. There is ST elevation in lead 2, lead 3, and AVF, an inferior region of the heart. And there is reciprocal change, ST depression in AVL. But look at this here, V1 and V2, and I don't know what you can say about that. It's an anterior. But this is there right ventricular involvement? So this ECG, this guy had inferior ST elevation myocardial infarct with a right ventricular infarct. It is important to recognize the right ventricular infarct in an ECG with an inferior because it complicates 40% of all inferior STEMIs. An isolated right ventricular infarct is very uncommon. These patients who have right ventricular involvement with their STEMIs are very preload sensitive because they have poor RV contractility. They can develop severe hypotension in response to nitrates or other preload reducing agents. They need fluids. So it's important to recognize that. You can do a right-sided ECG, V1 to V6, complete right-sided one, but it is easier to leave V1, 2, 3, and just do a V4R and V5R and a V6R. V4R is the most useful lead in telling us whether there's a a right ventricular infarct. And ST elevation in V4R has sensitivity about 88% and specificity of 78% and diagnostic accuracy of 83% in diagnosis of right ventricular infarct. Those numbers may not mean much, but I just want you to remember V4R. ST elevation in the right-sided leads is transient. In about 10 hours, it's present in the right-sided change of V4R elevation, V5, V6 is only present in some patients, in less than 50% of patients within 10 hours. They are very preload sensitive, as I said, and they develop severe hypotension in response to nitrates or other preload reducing agents. They need fluids, remember that. So, how do you spot a right ventricular infarction? As I've said before, just suspect it in all patients with an inferior STEMI. So you handed an ECG, think the patient has an inferior STEMI, look for a right V1, ST elevation in V1. So ST elevation in V1, only standard ECG lead that looks directly at the right ventricle. Then ST elevation in lead 3 will be greater than lead 2. Lead 2, because ST elevation in lead 3 greater than lead 2, because lead 3 is more rightward facing than lead 2. ST elevation in V1 will be greater than V2. And ST elevation in V1 plus ST depression in V2 is highly sensitive for a right ventricular myocardial infarct. And then there could be isoelectric ST segment in V1 with marked ST depression in V2, as shown in that lead. Look at that, there's isoelectric V1 with ST depression in V2. So confirm, remember you can confirm ST elevation in lead V3, V3R to V6R. Importantly, in these patients, no nitrates or other preload reducing drugs. Remember, it complicates 40% of inferior MIs. If inferior and right ventricular involvement, it's worse prognosis in these patients. Inferior MIs account for about 40 to 50% of all STEMIs, so it's important for us to look for right ventricular infarction. So generally, right ventricular patients with right ventricular involvement have more favorable prognosis than anterior STEMIs, with an in-hospital mortality of 2.9%. However, certain factors may indicate a worse outcome for these patients. All right, so that's one of the, that's the same patient here, V4R. I think this was done after some time, and you can see there's still V4R, there's still some elevation there. And actually, just even 0.5 millimeters is enough prognostication to confirm that that's a right ventricular infarct on V4R. So because of this, inferior STEMIs, right ventricular patients who have right ventricular infarcts can also present with heart blocks. All right, so this is an ECG here with an inferior STEMI with a 3rd degree heart block, with a 3rd degree AV block and slow junctional escape. 20% of these patients will develop significant bradycardia or heart block, 2nd or 3rd degree. There's an increase 20% in hospital mortality. Ischemia of the AV node is because of impaired blood flow to the AV nodal artery, which arises from the RCA 80% of the time. These patients can also have a vasovagal reflex, which is called basal-gyrich reflex, because of increased vagal tone secondary to ischemia. And heart blocks may occur stepwise. 1st degree heart block, 2nd degree, and then 3rd degree, or they can just be abrupt 3rd degree heart block. They may develop sinus node dysfunction. That is, there will be sinus bradycardia, sinus pauses, sinus arrest. And this is because the sinus nodal artery, which is supplied in RCA, actually in 60% of the population, but this is usually very transient and improves. In this context, there's another pearl here. This is a patient I saw who came in with chest pain, a 47-year-old male, again with chest pain, central, sharp. And there was a question here, is this acute pericarditis? I'll just put up that diagram there to illustrate some ECG electrophysiology. I'm not going to dwell much on it. But remember, with central, with this patient, I knew something that told me in this ECG that this is going to be the AVL lead. Because of the clinical history, and there's very, very subtle changes in AVL, as you can see there, but I thought this was going to be an inferior MI. Remember, in pericarditis, there are never reciprocal changes with pericarditis unless in the rare exception, there's a localized pericarditis, which is actually localized to the inferior wall. So AVL is a high lateral lead, electrically opposite to the inferior lead. So it will show reciprocity when there is a inferior MI. So ST depression with T-wave inversion in AVL may be a reciprocal change to an inferior STEMI and vice versa. So this together with morphology of the T-waves, which was somewhat straight there, and there's a normal T-wave morphology. You know, remember the normal T-wave morphology should be concave upwards, but this was straight. They're not concave, they're very straight. When T-waves start looking very straight, that is a marker of ischemia. So you've seen those changes there. I'll just show you the next ECG. 5 minutes later, actually, this guy declared himself, and you can see they're very classic. Look at how AVL has now classically very ST depression there. Look at lead 2, lead 3 there, and lead 2. So take home points: small ST and T wave changes in the limb, in the limb such as AVL and 3 can be significant. When there is ST elevation or even straight ST segments in the inferior leads, look closely at AVL. There's a blog somewhere which talks about AVL and AVR as a forgotten leads. Maybe you can Google that. I think it's in Smith ECG blog, but talks about the forgotten leads in ECGs. So look closely at AVL, and reciprocal ST depression and T-wave inversion can confirm an inferior STEMI and differentiate from other causes like ST elevation, other causes of ST elevation such as pericarditis or benign early repolarization. ST depression and T-wave inversion on its own in AVL may precede and predict an evolving inferior myocardial infarction. Hence the importance of doing serial ECGs. ST elevation in AVL and, and lead 1 can indicate a high lateral STEMI, excuse me, especially with inferior reciprocal changes. So look very closely for subtle ST elevation in 1 in AVL and seek out inferior reciprocal depression, which may provide an early confirmation of a high lateral STEMI. If in doubt, keep the patient for serial ECGs and troponins and consult someone with more experience. In this day and age, with smartphones, take a photo of the ECG and just consult a colleague. All right, so inferior MI, deadly, especially look for right ventricular involvement, look for Brady dysrhythmias, blocks, Brady's and blocks in these ECGs, and look for subtle AVL changes. All right, I think we shall keep questions to the end. Let's go to our second case. This is actually a patient I saw, an elderly gentleman who presented the aphorestic with chest pain 10 out of 10, but he had a normal blood pressure and he was just borderline tachycardic at 100. Right, who can tell us about that ECG? What do you see? Okay, the dark side of the moon. So I look at this guy has a posterior myocardial infarct. And the way I look at this is that this is the Earth and the moon. And this is, imagine this is your heart here and this is the ECG leads. So when you're doing the ECG, we are looking at the light side of the moon, the anterior cardiac wall. But remember, always there's something at the back. So I call it the dark side of the moon. When someone comes with an ECG and I see some changes in V2, V3, I consider it akin to the dark side of the moon. All right, or I call it actually a dead angle infarction. It's most commonly missed type of MI, and clinical presentation is not different. However, absence of classical ST elevation may lead to delay in diagnosis. Posterior MI accompanies about 15 to 20% of STEMIs, and is usually with inferior and lateral infarctions. Posterior extension of inferior and lateral MI implies a much larger area of myocardial damage. So that means there's more increased risk, there's increased risk of LV dysfunction and death. Isolated posteriors are very few. They account to between 3 and 11% of all STEMIs. The dark side of the moon, remember that. V2, V3, anterior ST depression, dark side of the moon, dead angle infarction. All right. So how do we spot this? Think of it, always suspect it, high index of suspicion. Anyone with an inferior lateral STEMI, look for a posterior extension. Remember the posterior myocardium is not directly visualized with the ECG as we said, and reciprocal changes of STEMI in this area are sought in an anteroseptal leads, V1 to V3. Such that these changes you're seeing in V2 and V3, those are reciprocal changes of a posterior MI. All right, so just some pulse here, V1 to V3, important leads. Horizontal ST depression. All right, look at that, horizontal ST depression. There's large, broad R waves and upright T waves. I'm not sure if that's really large and broad R wave, but that's one of the diagnostic criteria, and upright T's. Okay, so tall, broad R waves. I'll try and get an ECG to demonstrate that. So in patients with ischemic symptoms, horizontal ST depression in the anteroseptal leads V1 to V3 should raise suspicion of a posterior MI. So the anteroseptal leads, remember, are directed from the anterior precordium towards the internal surface of the posterior myocardium. Because the posterior electrical activity is recorded from the anterior side, so the typical injury pattern of an ST elevation and Q waves becomes inverted. So the ST elevation becomes ST depression, Q waves become R waves, and terminal T waves inversion becomes an upright T wave. Is there an easier way of detecting it? Because I think this probably might be difficult. You may miss, it's easy to miss and it's commonly missed. So yes, there is, just flip the ECG. When you see some changes in V2, V3, V1, V2, V3, flip the ECG, turn it around and flip it. See a flipped ECG. So that's, excuse me. So look at this ECG. There's a V1 to V3 ST depression. Flipped, you have ST elevation, confirming a posterior infarct. So anterior Rs become posterior Qs. Anterior ST depression becomes a posterior ST elevation. All right? So posterior leads, V7, posterior axillary line, level with V6. V8, inferior to the tip of the scapula. V9 is between V8 spine and the paraspinal line and the lower border of the scapula. So as with this again, 0.5 millimeters is enough to indicate ischemia. So look for a posterior MI in anterior ST depression. Yeah, right. Let me just get back to my screen sharing. I lost the screen a bit there. All right, yeah, so let's continue. So remember, the posterior leads will significantly increase the detection of a posterior injury. Sensitivity is about 66%, positive predictive value 96%, numbers don't matter here anyway. 15-lead ECG improves sensitivity from 49% to 94%. But remember, not all patients will need a posterior ECG. Yeah, so V1 to V3, remember, big Rs, ST depression, upright Ts, STEMI equivalent with ST elevation, V7 to V9. So this clinically, posterior myocardial infarction. And I know, so manage this patient accordingly. Right, this is the same patient, this gentleman, we did a bedside echo. I shall not belabor points on this echo. I think I shall skip this slide, but just this guy developed a mitral regurg, and he died about a few days later in this coronary care unit. This is another ECG, a common situation where the posterior coexists with an inferior and a lateral MI. There's a posterior extension of an inferolateral ECG, so inferior, lateral changes there, and look at that, V2, V3, reciprocal changes to the posterior MI. So be vigilant of posterior MI in any patient with an inferior lateral STEMI. This means there's more myocardial necrosis, more death. So more myocardium dies with a posterior MI, especially in anterior and inferior extension toward the posterior aspect of the heart. increased risk of left ventricular dysfunction and death, therefore deadly ECG, according to me. All right, so let's go to the third case. The third case is a 59-year-old male who had chest pain for 2 hours. He was intermittent chest pain and lightheaded, but when he came to my department, he was better. No pain, actually, he was pain-free. That is his ECG. So who can, the audience, just feedback on the ECG and what you think is wrong with that ECG. It could be a normal ECG, by the way, so if you think it's normal, just give your feedback. This guy had Wellens syndrome. What is Wellens? Who's heard of Wellens here? I'm sure many of us have heard. How do we describe Wellens? So these are pattern of deeply inverted or biphasic T waves in V2, V3, and sometimes V4, and could also be in the inferior region of the ECG. Highly specific for a critical left anterior descending artery stenosis. And patients are usually, not all of them, but patients are usually pain-free by the time the ECG is taken. They may have normal or just very minimally elevated cardiac enzymes, especially if you're using high sensitivity troponins. I don't know if you're using them here. And these are high risk for extensive anterior wall MI within the next few days or weeks. So a patient who has Wellens is at risk for extensive anterior wall acute myocardial infarction in the next few days or weeks. Is a prognostic indicator for badness. So due to critical LAD stenosis, these patients usually require invasive therapy. They do poorly with the medical management. This patient needs a cath. This patient needs to go to the cath lab. And these patients can suffer MI or cardiac arrest if inappropriately stress tested. So do not refer them for an outpatient stress test. That's another ECG showing Wellens. Look at these T waves in V2 to V3, very deeply inverted Wellens syndrome. Diagnostic criteria. So deeply inverted biphasic T waves, as you can see in that ECG, V2 to V3, and may extend from up to actually V6. There's isoelectric of minimal ST segment elevation, less than 1 millimeters, and preserved precordial R wave progression. The patients rarely have precordial Q waves, and they will report a recent history of angina, and the ECG pattern presents at a pain-free state. Most of these patients will come to you, they have the clot has maybe, they do not have pain. So the two patterns of Wellens described, maybe just a bit academic here. And there's a type A, which is biphasic, initial positivity and terminal negativity in 25% of the cases. And there's a type B, which is deeply and symmetrically inverted T waves. And they evolve over time. So type A evolves usually over time to a type B pattern. There's confusion in literature regarding the naming of T wave patterns, and some authors using type A for inverted and type B for biphasic. Therefore, it's better just describe the T wave pattern when you're talking to cardiology or referring this patient for intervention. Remember, do not take them for stress test. This is the same patient's ECG, the initial ECG I showed you. This guy went for a cath lab the same day. And look at that LAD complete stenosis. So maybe let's try and understand how this T wave pattern, this T wave changes and why they are there when there's no pain. So number one, you have a sudden acute LAD blockage, which leads to transient ST elevation anterior STEMI. The patient has some chest pain and diaphoresis, some MI symptoms. And most of the time, this stage is not captured because by the time they get to you, maybe they're pain-free. And then they reperfuse. There's reperfusion of the LAD, that is spontaneous clot lysis or aspirin pre-hospital, and they reperfuse the LAD. The chest pain resolves, the ST elevation improves, and the T wave becomes biphasic or inverted. So T wave morphology identical to patients who've had a reperfusion of a successful PCI. Then the artery remains open, the T waves evolve over time from biphasic to deeply inverted, but the coronary perfusion is unstable, and the LAD can reocclude at all. Can reocclude at any time. Reocclusion happens, and the first sign on ECG is apparent normalization of the T wave, the so-called pseudo-normalization. The T wave switch from biphasic, inverted to upright and prominent. This is a sign of a hyperacute STEMI with reoccurrence of chest pain, although the ECG changes can precede these symptoms. Then the artery remains occluded and they get an anterior STEMI. Alternatively, some patients might have a stuttering pattern that may develop with intermittent reperfusion and reocclusion. That is ICG with Wellens, pseudonormalization, and then STEMI. So remember, these changes are not isolated to the anterior leads. They can develop in the inferior leads, in the lateral leads, with right coronary artery occlusion or circumflex occlusion. Just have a very interesting ECG series here of a patient that one of my colleagues saw. This young patient presented, and the ECG was in the emergency department. So he just came into the emergency, and you can see these ECGs are sort of the ones captured by the paramedics and the ambulance with their machines. They're not typical ED machine recordings, but so he was in the emergency department, still had the ECG leads from the paramedics because you're supposed to be taken straight to the cath lab, but there was a little bit of delay and he stayed in the emergency department for about 48 minutes, so 50 minutes. So this ECG is very interesting. The series shows a very stuttering pattern. You can start at 0 minutes there when the patient arrives. He had anterolateral STEMI, very well shown by that ECG, hyperacute T's, and these are inferior reciprocal changes. Look at lead 3 there, and which were very really typical LAD occluded. Then at 15 minutes, an ECG was done, and there was a typical Wellens pattern. Look at that, biphasic T's, type A pattern in V2 and V3, and improvement of the anteroceptor ST elevation, including reperfusion, indicating reperfusion. At 35 minutes, there's recurrence of pain and the pseudo-normalization of the precordial T waves, right? And at 40 minutes, there's ongoing pain. This guy gets ongoing pain. Look at that. Look at those changes again, nearly akin to the first ECG, evolving an anterior STEMI. And then at 48 minutes, just before he went up to the cath lab, he's almost pain-free again. And look at that Wellens and T waves biphasic again. The artery has reopened. So I just want to thank Dr. Andrew Bishop for that series of ECGs. And yeah, very interesting Wellens progression on anterior STEMI. So what is the significance and why did I choose this Wellens as one of the deadly ECGs? Due to critical LAD stenosis, these patients usually require invasive therapy. They do poorly with medical management. Do not send them for a stress test. Send them to the cath lab. They may suffer an MI or cardiac arrest if inappropriately stress tested. And they often need invasive strategy, a stent or a cabbage. If you stress them, you kill them. Remember that. The inciting event of a Wellens pattern in ECG does not necessarily have to be a thrombus formation. It may also occur in a normal coronary artery following episodic vasospasm, like snorting of cocaine, like this guy, not the Coca-Cola and the drink, the cocaine itself. So that can bring vasospasm and you can have a Wellens picture, right? That's an ECG of a pseudo Wellens. And you can see, look at that beautiful T-wave inversion there. Look at that. And deep biphasic T's, minimally elevated or isoelectric ST segments, and no precordial Q waves. The patient has recent angina, and the ECG, this ECG was taken in a pain-free state. This patient had no troponin leak. Normal coronaries when he went to the cath lab, right? So that is still the same as this one was taken after a patient had crack cocaine and had a pseudo Wellens picture. Right, so differential diagnosis of Wellens is varied. There could be mimics, such as this pediatric ECG. Let me bring it up. That's a pediatric ECG, and that is not Wellens. So pediatric ECG, who can tell us what that is, what that picture is on a pediatric ECG? Yeah, that's a persistent juvenile pattern, which is normal in pediatric ECGs. Morphology of T-wave changes is quite distinctive. However, there are numerous other conditions that may produce a similar pattern of precordial T-wave inversion. Pulmonary embolus, right bundle branch block, right ventricular hypertrophy, LVH, HCM, raised intracranial pressure, persistent juvenile pattern in that ECG, pediatric ECG, Brugada syndrome, you can get that, and hypokalemia, you can get Wellen-like picture. So those are some mimics. As always, the money is in the history and the clinical presentation. Okay, so deadly Wellens, remember that. Okay, I'm just going to go to my fourth case now. So typical Aussie young male, 38-year-old, complaining of chest pain and chest tightness after having a large meal at KFC. He felt like his normal indigestion, and he has been getting over the past few months, but this was a bit more, and he presented to our department. What do you see in that ECG? Right. What is that? Look at that. Widespread horizontal ST depressions in lead 1, 2, V4 to V6. ST elevation in AVR, which is more than 1 millimeter. ST elevation in AVR, which is greater than V1. That is a left main coronary artery obstruction, global ischemia. Is this bad? Yes, very bad. The left main coronary artery disease, not occlusion, as full occlusion would rapidly lead to STEMI and cardiogenic shock and death. We have to pick it up. LMCA, bad. Look for AVR, look for global ischemia on the ECG, and these patients need urgent action. AVR, ST elevation in AVR is, as I told you earlier in the other ECG, there is a blog that talks about AVR and AVL as the forgotten leads. But ST elevation in AVR is not entirely specific for LMCA. It may also be seen with proximal LAD occlusion, severe triple vessel disease, and diffuse subendocardial ischemia, like e.g., when you have a cardiac arrest and there's oxygen supply demand mismatch following resuscitation from cardiac arrest, you can get the AVR, ST elevation in AVR, which will be an indication of diffuse subendocardial ischemia. Whatever, this is bad, no matter what, ST elevation in AVR is bad. Some authors argue that the term LMCA occlusion is inaccurate, as most of these patients have at least some flow in their LMCA. So incomplete LMCA occlusion, whereas a complete LMCA occlusion would rapidly lead to STEMI, cardiogenic shock, and death, as I said. Okay, so mechanisms of ST elevation. So this is just another, going back to that same slide of ECG, anatomy, and pathology. So this is a very important slide, I find. So when you have time, you can look at it. You can get in life in the first line. Right, so whatever, as I said, AVR, ST elevation, bad. Some authors argue, as I said before, that the occlusion is never complete, it's partial. Mechanisms of ST elevation in AVR is, I'm not going to belabor the point. And so when you see AVR, ST elevation, diffuse subendocardial ischemia, most probably proximal LAD occlusion, right? So AVR is used in this LMCA infants as a predictive value in the context of widespread ST depression and symptoms of myocardial ischemia. ST elevation in AVR greater than 1 millimeter means proximal LAD or LMCA occlusion or severe triple vessel disease. ST elevation in AVR greater than 1 millimeter predicts a need for a coronary artery bypass graft. ST elevation in AVR greater than V1 differentiates LMCA from LAD occlusion. Absence of ST elevation in AVR almost entirely excludes significant LMCA lesion. Okay? ST elevation in AVR greater than 1 millimeter is highly specific for LAD occlusion. I'll repeat that. In patients undergoing stress testing, ST elevation in AVR greater than 1 millimeter predicts LMCA or osteo-LAD stenosis. Okay, and AVR change is also a predictor for mortality and morbidity in patients with acute coronary symptoms, and I'll let you read that. Okay, so this is a STEMI equivalent. ST elevation in AVR, proximal LAD occlusion, severe triple vessel disease, diffuse subendocardial ischemia. Given the ability of ST elevation in AVR to predict critical coronary artery lesions and death, this ECG pattern is increasingly being recognized as STEMI equivalent, and it is a STEMI equivalent. Requires urgent reperfusion therapy to prevent cardiogenic shock and death. Presence or absence may potentially inform the decision to give platelet inhibitors, clopidogrel, ticagrelor, or whatever you use. As patients who have triple vessel disease may require CABG with increased risk of bleeding if they are anticoagulated. So discuss with the receiving cardiology team. All right, so medical therapy in these ECGs is less, in these patients is less useful. They'll need invasive reperfusion and usually a CABG. Kosgei and all wrote a paper in 2011 which said ST elevation in AVR greater than 1 millimeter is a strong predictor of severe LNC and triple vessel disease requiring a CABG. Discuss treatment, especially anticoagulants, with the cardiologist before the patient goes, before you give the patient these things, because there's an increased risk of bleeding, right? This is another more subtle ECG showing a proximal LNC occlusion. There's ST elevation and Q waves in V1 and V2, as you can see in that ECG. There's ST elevation in AVR. There's widespread ST depression in lead 1, 2, V5, and V6. And this most likely a proximal LAD occlusion. All right, another example here. Widespread ST depression in V2 to V6, lead 1, 2 AVL. There's ST elevation in AVR, which is greater than 1. And there's death and extent of the ST depression indicates severe subendocardial ischemia. So remember, these ECGs, we have to keep on looking at them as repetition is the mother of all memory. The more we look at them, the more we remember. It's basically pattern recognition, all the time, pattern recognition. All right, so this is another ECG showing LNC or severe triple vessel disease. You can see the ST horizontal downsloping in multiple areas, V3 to V6, 1, 2, and AVL, and ST elevation in AVR is greater than V1. Okay, again, there's some mimics in these ECGs, and remember the key, the man is in the history of the clinical presentation, and add and now look at the ECG and make a decision. So widespread ST depression with reciprocal changes in AVR are common in AV and RT of AF. Significance is unclear. Query, is it rate-related ischemia? Is it unmasking of underlying coronary artery disease? Is the electrical phenomena in the young? We don't know. The concern always is ST depression that persists after reversal into sinus rhythm. Signs of clinical instability, chest pain, diaphoresis, hypotension, and syncope, and elevated cardiac enzymes with troponin rise. And remember, older patients with multiple risk factors. Right, so that's a deadly ECG. Okay, I'm just going to take a small break here before we continue with the second part of my presentation. Thank you, small break.